Right, I hope I'm through, and this is part of explaining some more rare mental health problems. And today I would like to talk about dissociative or conversion disorders. The terminology has changed quite previously, when we had these transformations from ICD-10 to 11 or DSM-4 to DSM-5. But in summary, what we have is we have a disturbance of normal motor, sensory, or cognitive functions, which look like they are neurological. They could look like an epilepsy or other physical problems, which then later are attributed to psychology. Usually, years ago, these disorders, when you looked at this first studies by Freud, they were explained by psychodynamic mechanisms, repression of whatever unacceptable impulses, and their conversion to physical things. And sometimes, when I think one of the most common things is this arc the circle, which has some sexual and symbolic meaning. Anyway, these very complex things have been abandoned, and so psychodynamic mechanisms are no longer important, but it's still accepted that some psychology conflicts or stresses can influence the presentation of conversion or dissociation. Usually the classification is whereas physical symptoms or related symptoms, dissociative disorder are usually taken separately. In ICD-10, dissociation and conversions are used in a similar way, but so they put the symptoms, let's say, let's focus on the symptoms instead of focusing on this different type of naming. What are the clinical features? The clinical features can be a paralysis, so people may not be able to move a limb, or they might not be able to smile anymore. They usually have whatever soft paralysis. Sometimes people have be able to develop severe contractions. Sometimes the examination of a limb, arm, or leg is impossible, but other movements, when you move other parts of the body, they can function partially at least. Loss of speech is common. People don't understand, and they do understand the speech, but they can't speak anymore. They might only be able to whisper. Writing might be completely fine, and the larynx usually is normal, as are most of the symptoms, the physical symptoms. Some people might feel that there's a sensory loss in some parts of the body, which very often have this glove-type distribution, and less commonly the neurological distribution into different areas. There's some, and this is why I must admit, I was one of my first patients who had non-epileptic seizures, and these are usually, and initially when I saw him, I always said to the consultant, I might not be having seizures, but as he did, he just initially came to me, then showed me the seizures, and I thought that can't be real. But then again, he had some epileptic fits. So I think now I learned over the years that, both is real, and, so both is real, and these seizures consist of what the patient experiences. And so, yes, the epileptic seizures usually have confusion and biting of the tongue, but that's usually in a different way, also felt in dissociative seizures felt by the patient. Amnesia is very common. People might not be able to memorize things, but on the other hand, they then have very, very selective memory for other events, and can remember parts, and especially parts where other people haven't done what they would have expected them to do. There's some parts where there is an associated dissociative amnesia, where people have whenever travel, go to other places, so they can't remember them, where they've gone, how far they've come. But even though we might be able to find that they have them function completely normal during the time when someone has seen them on the bus or on the drive or in the car. So these are possibly memory losses, and the diagnosis is usually made by physical and neurological examination to exclude underlying physical house problems. Then finding positive signs of of these events. Then to find some explanation for the event, people can explain why they can't move. That's usually helpful. Usually over-helping in the treatment might not be very good, because so it's no point people have a dissociative paralysis that they are provided with a wheelchair or with crutches, because that might make it worse. So usually some I think what I would usually call as bridge building is more helpful. Some CBT or supportive psychotherapy and physical health problems are more important. And if people get what we call a bridge and some understanding and some support in their physical and mental health problems, the resolution of symptoms can be quite good. Yes, some might come back, whatever, 10, 15 years later, or in the similar circumstances of stress, but usually the outcome should be not too bad. Okay, that's about dissociative disorders. As I say, this is just an overview. It's not a teaching. It might help people who have some interest in mental health and might have family members and maybe some junior doctors, but this is not meant to be the most scientific part. It's meant to help people who might be interested in mental health in general. Okay, thanks a lot and goodbye. And if you're interested in such type of information, you may consider subscribing to our YouTube channel, Global Psychiatry Archives in general.